Renal disorders and management. Acute kidney injury is the new term that covers everything from mild impairment to acute renal failure. It means you have an abrupt decrease in your glomerular filtration rate with azotemia and an inability to maintain electrolyte and acid-base balance. There are 3 types, and they're listed in the box on page 792. Pre-renal renal failure takes up 58% of all acute renal failures, and some of the causes are dehydration, hypotension, decreased cardiac output, anesthesia, emboli, or sepsis. Intrarenal renal failure takes up about 34% of all types of acute renal failure, which is what the definition is at the top is for acute renal failure. The most common type of intrarenal renal failure is acute tubular necrosis. That occurs about 90% of all cases. It could also be from acute glomerulonephritis or pyelonephritis. Post-renal renal failure, on the other hand, is only about 8%. Usual cause for this is stenosis, calcification, BPH, benign prostatic hyperplasia or hypertrophy, neurogenic problems, bladder obstruction, or infection. The Rifle criteria is used to determine the degree of acute kidney injury. Rifle stands for risk, injury, failure, loss, and end-stage renal disease. And this is on page 791 in your textbook where they discuss that. Symptoms, there's a table on page 795 through 796 that talks about the different lab values that go along with the different types of renal failure. Risk factors for all of it are aging, your GI bleed, sepsis, burns, rhabdomyolysis, multiple organ dysfunction syndrome, central nervous system changes, and OB complications. Acute tubular necrosis risk factors are glomerulonephritis, hypertension, diabetes, crush injury, rhabdomyolysis, nephrotic drugs, and poisons. And there's a whole box on page 793 that they talk about. Acute tubular necrosis, which is, since it's 90% of all types of acute intrarenal renal failure, there's a box on 793 that talks about the cause. And you can have ischemic, which causes cast formation and cell damage, where the kidney is unable to autoregulate, or toxic, where it recovers faster is because the base membrane itself is not damaged as severely. There are 3 phases of acute renal failure. Onset is from the time of injury, the time of the insult to the injury. This can be hours or days. Treatment here prevents permanent damage. And you'll have 50% of your patients with output greater than 600 milliliters in an 8-hour time frame because, remember, you've got 2 kidneys and both may not be damaged. The anuric phase is also called the oliguric phase. Anuric means no urine. Oliguric means less than 400 milliliters a day. And this lasts for 5 to 8 days if it's non-oliguric, 10 to 16 days if it is oliguric. So it can also be called the maintenance phase, depending on which textbooks you're reading. The diuretic phase lasts 7 to 14 days. During this time, pardon me, the kidney's starting to recover, and so you're going to have between 2 and 4 liters a day out. The recovery phase is when your GFR increases to 70 to 80% of normal, and unfortunately that sometimes takes 1 to 2 years for that to occur. Acute renal failure, your assessment, the abnormal labs are on page 794 and 795 to 796. You're going to definitely have hyperkalemia. Your creatinine will be increased with 50% of your nephrons damaged. Hemodynamic monitoring will show a CVP that is elevated due to fluid retention. Your pulmonary artery occlusive or wedge pressure will be elevated for the exact same reason. You'll have too much fluids on board. Your cardiac output will be increased because of that increase in blood pressure and increase in heart rate. With your vital signs, you may have Kussmaul's respirations because of the metabolic acidosis. Remember, fast and deep. Daily weight, they'll be gaining weight. They may also have a friction rug if they're uremic. They may have some neurologic changes because of an elevated ammonia level or BUN level. And remember, it's BUN, blood urea nitrogen. A BUN is something that you eat or look at. They're professionals, it's a BUN. You need to assess for uremic frost, which is like little white crystals you'll notice in dependent areas, in areas where moisture collects, because the body has to excrete waste products somehow or another. An abdominal girth needs to be done, and you'll notice that it will be increasing the longer they're in failure. And the patient will also be in metabolic acidosis. And remember, we talked about the spot urine sodium. If it's less than 10, it's pre-renal. If it's greater than 40 with an elevated creatinine, it's intrarenal. So you may have a nephrologist ordering a spot sodium. With acute renal failure, the treatment is to maintain the fluid balance between about 1,500 milliliters per meter squared every day. And yet low-dose dopamine works, 2 to 3 mics per kilo per minute, but it should only be short-term. There's a table on page 802 that talks about the IV solution that you can use, crystalloids or colloids, but there really hasn't been any clinical difference between using crystalloids or colloids, and crystalloids are a whole lot cheaper. Remember, those are your regular IVs, where your colloids are your albumin and your dextran, things like that, of that nature. Colloids, your albumin helps if you've got a lot of fluid third spacing to pull that back into the vascular system because of the protein that has been lost through the kidneys. So sometimes that does help. Fluid restriction to 1 liter if the output's only 500 milliliters in 24 hours or less, because remember, they're going to have an insensible loss of 500 to 750 milliliters a day. If it is intrarenal renal failure, they'll be getting diuretics and hemodialysis. You want to maintain their electrolyte balance because remember, they're very hyperkalemic. So you may infuse dextrose and insulin to push that potassium back into the cell. Bicarb, 40 to 160 milliequivalents will be given if the pH is below 7.1. Kayexalate can be administered to lower that potassium, and you can give it either as an enema or as a drink. If you've never seen Kayexalate, it looks like liquid stool, and it kind of smells like it too. So I highly recommend giving it as an enema. It's only about 60 milliliters. It's not a big deal, rather than making your patient drink it. Now, if you're putting it down an NG tube, that's another matter, but it just is not aesthetically pleasing. Dialysis can also be done, and we will talk about that in a little bit. Hyponatremia, you can administer 3% saline very slowly, 250 milliliters very slowly, because you don't want to send your patient into heart failure. Hypocalcemia, you can give calcium supplements. Hyperphosphatemia, you're going to give aluminum hydroxide, and remember, because that will decrease the phosphate, but you need to give it with the food to decrease the phosphates in the food. Otherwise, all it's going to do is increase your calcium levels. Nursing diagnoses for acute renal failure you'll find on page 804. Nutrition, TPN may be given. The renal diet will be one that's low in potassium, low in sodium, protein 1.2 to 1.5 grams per kilogram, which is low, works out to be about a 60 gram protein diet, and it has to be high in carbohydrates because you need calories in something. Medications, diuretics, they're on a table on page 803. Both osmotic and loop diuretics will be given. Your textbook says loop diuretics help the clinicians feel better because you get a rapid output, but they don't affect the patient outcome necessarily if you're in the oliguric acute kidney injury, acute renal failure. Vasodilators, dopamine and Lasix. We talked about low-dose dopamine that can be given. Calcium channel blockers because they're vasodilators. And again, the phosphorus binding agents. And as I said, they must be given with the meal to lower the phosphorus Otherwise, they just increase calcium levels. Acetylcysteine, mucomist, can be given to vasodilate the kidneys. It scavenges free oxygen radicals, and you give it if you have an elevated creatinine and need an IV dye exam. You get 600 milligrams twice a day before and of the day of the exam. But they've done some research, and they found no difference between the mucomist and rehydrating the patient with saline, normal saline, for patients who have a creatinine that's elevated before the exam. So you may work in an institution where they don't give the acetylcysteine, they just give lots and lots of sodium, saline ahead of time. Phenoldiprem or Corlopam is a dopamine 1 receptor agonist. It's similar to dopamine. This is also given to vasodilate before the exam, and there are no current studies at the moment that look at phenoldiprem. Your nursing care, you want to avoid infections. It's really important. Cough and deep breathe, position changes, intake and output. Daily weight is more important than intake and output. Assess for anasarca. Anasarca is total body edema. Assess for anemia because of that decrease in erythropoietin, and that is a complication of this. And if you do have anemia, you will receive Procreate, Epigen, epoetin alpha, something like that, at least once a week. Nursing diagnoses are on page 804, as I think I've already mentioned, and patient education is on page 805. Now, I promised you to talk about dialysis. Here's dialysis. Temporary dialysis is by vascular access. A Quinton cath or a double lumen catheter. Quinton is a trade name. And there's a picture of this on page 807. Chronic dialysis, there are pictures on page 808. They'll have either a fistula, a graft, or a shunt. With the fistula, you risk arterial insufficiency. You need to assess for a bruit and a thrill. Now, a bruit you listen to, and that indicates turbulent flow. And there's going to be turbulent flow because these are not normal to have a fistula, a graft, or a shunt. A thrill is when you put your hand very lightly over the site and you feel the blood go through there. Hemodialysis, the indications for it are in a box on page 805, but there are things like a BUN of 90, creatinine of 9, and hyperkalemia. Someone who has severe drug toxicity, either prescribed drugs or non-prescribed drugs. Metabolic acidosis, someone who has the symptoms of uremia, mental status changes, and fluid volume overload. Contraindications is if you have a patient who's unstable, has no IV access at all, or you can't anticoagulate, you can't cause them to, their blood doesn't clot, for somebody who has, say, DIC, where the blood does not clot appropriately. Symptoms of uremia might include a GI bleed and pericarditis. Hemodialysis, there's a diagram for it on 807, and on 809 there's a table of complications of dialysis and management of that AV fistula or graft, and you'll want to look at those. Another form that can be given is your continuous renal replacement treatment. Now, this will last for 12 hours or longer. You can do this even though the BUN is only 60, but you need a mean arterial pressure of greater than 70 millimeters of mercury. You can do it if it's lower, but it doesn't work quite as well as it should. The ultrafiltrate is drained by gravity, and you have 5 to 45 milliliters an hour out that is drained. It does require anticoagulation, but you can use this if your patient is unstable, as long as their hematocrit is over 45. There's a table on 814 for the problems and nursing interventions for continuous renal replacement therapy. That second C should be another R, so it should be CRRT. Indications, contraindications are also on page 811, and the different types are on 810, and the pictures are on 812 to 813. Complications of continuous renal replacement therapy, dehydration, hypotension, electrolyte imbalance, acid-base abnormalities, hypothermia, hyperglycemia, and as I said, that's on page 814, a table that also includes the nursing management. You can also have a clotted hemofilter. If it disconnects, you can hemorrhage. There's a box on page 815 that you'll want to look at also. Infection's always a possibility. Peritoneal dialysis, there's a figure that shows it on page 816, and the National Intervention Council, or NICs, are listed on page 817. Indications for use are uremia, volume overload, electrolyte imbalance, lack of IV access, hemodynamic instability. Contraindications, adhesions, recent abdominal surgery, significant pulmonary disease, peritonitis, and the need to remove all that fluid in a hurry. Now, the recent abdominal surgery is like 6 weeks. You have to warm the fluids to body temperature. You can't put in cold fluids into the abdomen. There's a picture on 816 for placement and a table on 817 to 818 for complications in nursing management. Pharmacologically, diuretics might be given. Methylxanthines that are very similar to your thiazide diuretics. Your phosphorus binding, like your Amphigel, and we've already discussed how it must be given with the meal to decrease the phosphorus, otherwise it just increases the calcium. And Epigen, or erythropoietin, which you've already discussed. And that finishes the renal